next case has to do exactly with a patient who has this disease. What is Friedreich's disease? Does anybody know what it is? Do you think it's some kind of a neurologic disorder which leads to something that you might call ataxia? Or is it some autoimmune disease? And I'm just giving you another case with an autoimmune disorder. Or do you not really care and you don't even know who Friedrich is? And why would you want to care what kind of disease he has? Or is it some form of cardiomyopathy that leads to sudden cardiac death, or alcohol intoxication? Okay, I'll give you a few more seconds to answer this. Okay. Don't forget, you can always ask questions. And you can raise your hand. And coming back to Yvonne's question from before, yes, pulmonary embolism was certainly an option in a patient, and we performed ventilation perfusion scanning in him, and we also performed spiral CT. We didn't find pulmonary embolism. The only thing we found in MR was plaques in the myocardium, especially in the right ventricle, which showed that his problem was truly right ventricular myocarditis. Okay, I think most of you have voted. Oliver, can you show the results? Okay, here we are. Good, very good. I think most of you know that it is a neurologic disorder leading to ataxia, and this is exactly the way the patient presented to us. He was in very poor neurologic shape. You see that Friedreich ataxia involves the CNS and also the peripheral nerves. It causes ataxia. It can also involve the pancreas, but it can also involve the heart. And this is why I'm showing you this case. But just as a little review before I show you the case, basically you can find all sorts of different symptoms in these patients and signs. But with respect to the heart, what you usually find is hypertrophic cardiomyopathy. So a thick muscle with sometimes even reduced left ventricular function. But our patient presented like this, and I'm calling this case one cylinder because this is probably one of the poorest ventricles that I've ever seen. I mean, you've probably all seen ventricles which are poor and very poor, but this is very, very poor. So this is almost a mirror of the case I showed you previously, only that he has poor left ventricular function, and the left ventricle is practically not alive. You can see that you have just a bit of motion of the septum. Most of it is actually caused by the right ventricle and by volume of the right ventricle, not as much by the contraction of the left ventricle. You can see that there's dysynchronous motion. He also had left bundle branch block. And the reason I'm showing this case is because, again, you can see very nicely things that point to a reduction in left ventricular function and also to poor left ventricular function and poor prognosis. Take a look at this aortic valve. If you look closely, you will realize that this patient has premature aortic valve closure, actually. I'm going to show you this. Let me go back to this image here. If I put this M mode right through the aortic valve, what you will see is, you will see that the aortic valve closes before the T wave. A very short aortic valve. Why is that so? Well, because the patient has very low cardiac output. This is the LVOT velocity, which is extremely low. And I actually calculated the cardiac output in this patient, and he had a cardiac output of below 2 liters, which is very, very low, especially for a man who was fairly tall and had a fairly normal body surface area for a man. So basically, you can see this patient has very poor left ventricular function just by looking at the hemodynamics. The same is true also for the pulmonic flow. Pulmonic flow is equally reduced, and this is a very strong prognostic factor. So if you go, for example, and just trace, for example, here the curve, and if you have velocity time integral of below 12, that usually means that someone has poor prognosis, and he has 4. So this is very, very poor. In addition, just look at the Doppler signal across the mitral valve. Now, first of all, he has very little flow across the mitral valve, also a sign of low cardiac output. But he also has a very steep curve. You can see the deceleration time is very short, and the A wave is relatively small compared to the E wave, which means he has restrictive filling pattern and high filling pressures. And if you look at the mitral valve, this is the 4-chamber view, you can see he has a typical myopathic pattern of opening, so the mitral valve is not even opening completely. And then look at the flow here in the left ventricle. I don't know if you can see that on your screens. I'm just going to increase the gain so you can see the slow flow in the left ventricle. This also means poor prognosis. Okay, right ventricle function is also very poor. What else can you do? Well, what else can you do is you can, for example, use the M mode here right at the level of the mitral annulus and see how much motion there is of the annulus. And if the annulus motion is below maybe 15 millimeters, you know that the longitudinal contraction is reduced as well. But you might see that just by looking at it, so you don't even have to do this. Okay, now what else do you see? You see that the patient has abnormal septal motion, and if you perform an ejection fraction calculation, you would probably get an ejection fraction somewhere in the range of maybe 4. And then the last sign I want to show you is this. Remember, I mentioned speckle tracking as a method to look at longitudinal function, and this bullseye plot very nicely shows you that there is practically no contraction in the ventricle. Normally, these values should be in the range of maybe 17, 18, 19, or even 20%. In this case, we have much lower values, and the global longitudinal peak systolic strain is in the range of minus 4.3, much too low. Okay, so I think this just shows you the potential again of echocardiography to not only make the diagnosis of cardiomyopathy, which was quite obvious in these patients, but even more so to see how severe the problem is and obtain information which is very valuable if you monitor these patients and if you want to make decisions.